I wanted to follow up on the video that I showed, the two videos that I showed, and hopefully relieve some anxieties and answer some questions before you ask them. You're not going to have to know what the numbers are on those absorption coefficients. You're not going to have to know how to calculate those things. Again, that's too deep for what we need to know at this point. We're not even going to cover those in the program itself. So what I wanted you to pull from those are a couple of different things. One is that in order to see the image, we have to have that differential absorption. So we have to have a KVP in a reasonable range, even though our computer algorithm, our lookup table is what is responsible for our contrast primarily. We still have to have that physics inside of the patient where we have the difference in absorption rates between different tissue types so that we can see those on the image. So that's your differential absorption. The rate of absorption inside of soft tissue versus the rate of absorption inside of bone versus the rate of absorption inside of air or contrast media or anything like that. So that's one. You need to know that we have to have that difference in order to see the difference on X-ray. That's number one. Number two is that the higher the KVP goes, the closer those coefficients come together. So we have to have differential absorption, but the higher the KVP gets, the less difference we have in those tissues. And you can get to a point where you penetrate all tissue types so similarly that you can't see any contrast between them. So even though your computer algorithm is what controls your contrast, you still have to feed your computer algorithm a difference in absorption inside of the tissue that it can make sense out of. Otherwise, it can't work with it. That's that old computer saying that you're only going to get out of a computer what you put into it, and that way you get garbage out for garbage in, or better said, or more commonly said, is garbage in, garbage out. So if you shot all of your extremity work with 100 kVp, your differential absorption will be minimal, and you might actually lose some contrast. Now we're going to talk about technique and setting technique. And what we're going to divide this into are patient factors and then effects on image quality. And we're going to talk about image quality, optical density, contrast, detail, and distortion for the rest of the semester. So patient factors include body habitus, part thickness, which is not necessarily the same as body habitus, body composition, which is not necessarily the same as either one of those two, and all of that can be affected by pathology. So your body habiti, your different body habitus would be sthenic, which would be thin but muscular. Hyposthenic would be fit but thin. So the difference between those two would be somebody who does maybe some weight training here as opposed to somebody who does a lot of aerobic training. So maybe a runner's build or a swimmer's build. And then we have hypersthenic. Now, hypersthenic is a heavy patient or a heavy person. And then asthenic would be somebody who's very, very thin and frail. Those are your older patients who are in nursing homes, really skinny patients who appear to be somewhat emaciated. So your patient factors include thickness. It may be body habitus or it may not be. It may be thickness as it pertains to muscular development. So you've got a couple of things in muscular development. You've got hypertrophy, and hypertrophy is an increase in size, and that increase in size is because of a stimulus. So you've got somebody who's maybe a bodybuilder, and it's especially dramatic in somebody who does bodybuilding along with maybe anabolic steroids, and they get really, really big. I went to school with a guy who was, he competed, and he went pretty far. He won, I think, Mr. Mid-America, And he quit working out, quit taking the steroids, and he got significantly smaller. Okay, so hypertrophy is because of a stimulus, you got large development. And then hypotrophy is the opposite. It's because of the lack of stimulus that you lose tissue types. So it's basically underdevelopment because of disuse. And thickness can be secondary to a different condition. So bowel obstruction may give a patient an appearance that they are very large and thick. But in that thickness, you got to consider what's underlying that. You know, is it thickness because of soft tissue, increase in soft tissue, or is it thickness because of gas or some other factor? And then edema would be a definite increase in thickness because of soft tissue or specifically water buildup in the tissue itself. So in these cases, what we've got is if you've got a patient who is very large, very thick, regardless of whether it's body habitus or body development, your go-to adjustment is mass. You increase your mass in proportion to the thickness. So if the thicker the tissue gets, the more of an increase in mass. So I'd refer you back to that video that we saw in the last recording. And the amount of increase in mass according to tissue can be quite dramatic because of the absorption in those tissues. So if you have a patient who has hypotrophy, and that is a loss of tissue because of a lack of stimulus, well, it depends on what is causing the hypotrophy and what tissue type. So if it's a loss of soft tissue, then again, it's going to be mass. But in hypotrophy, let's say you have a patient who has disuse atrophy of bone. The cortex of the bone can become so thin that the bone and the soft tissue look a lot alike. In those cases, you may have to decrease the KVP. So a bowel obstruction, again, as opposed to edema, a bowel obstruction, it looks like the patient has a tremendous increase in soft tissue, but what you get with a bowel obstruction is a lot of buildup of air. So you may have to decrease your technique, specifically mass. And with edema, you get an increase in soft tissue and water in those tissues. So you would increase your mass. You don't want to increase KVP with edema. You could theoretically decrease KVP with a bowel obstruction, even though it would just increase patient dose. With bowel obstruction, you'd want to decrease your mass as well. But with edema, you would definitely want to increase your mass, because if you increase KVP, you're increasing the technical factor that creates a higher percentage of scatter radiation in tissue types that increase the percentage of scatter radiation as well. So definitely increase your mass with edema. So what we're talking about is tissue composition, Zeph number, and whether or not we've got an increase in a Zeph number that would warrant an increase in KVP, or does it just warrant an increase in mass? So most of the time it's going to be mass, but if you have a tissue type or an increase, a significant increase or decrease in bony tissue, then you might want to adjust your KVP. But most of the time, if it's soft tissue or air, which are going to be most of your pathologies, or a loss of bone, then mass is usually what you're going to change. So density. Density is just the blackening of the image, and we talked about that, and we used a couple of different examples. But it's just the overall blackening or the darkening of the image. And it's not the same thing in the patient as tissue thickness. Density involves the Zeph number and the composition of the tissue type. So as we have an increase in tissue density, we have to increase technique. And most of the time, again, that's going to be a mass increase. I touched on this earlier. You have two different types of pathology. You have additive and destructive, and the difference between the two is what kind of tissue what does it do to the tissue? Does it add patient density to the tissue? Does it remove patient density? So an additive condition would be where you increase patient density. Now, understand patient density and radiographic density are inversely proportional. As patient density goes up, radiographic density goes down. So the blackening of the image, the darkening of the image is going to decrease with increase in patient density. So think about the difference between bone and air. Bone is a very dense tissue, and it gives us a decrease in density on the image. So additive would further increase that. So things like osteopetrosis, increased bony tissue. The increase in bony tissue is an additive condition, as opposed to osteoporosis is a destructive condition because it removes patient density and increases radiographic density in that tissue type. So again, patient density, how hard is the tissue? How solid is the tissue? How hard is the tissue to penetrate? Radiographic density, how bright or how dark is the image of that particular tissue type. So the darker the image, the darker the density on the image, but the lower the patient density. So additive pathologies create patient density. They absorb more x-rays than the normal tissue. I say healthy tissue here, but it could be healthy tissue and still have an increase in tissue type or tissue density. So it absorbs more x-rays than normal tissue and therefore decreases radiographic density. Destructive pathologies decrease patient density, so they transmit more x-rays than normal tissue, and it increases radiographic density. So if you add examples of additive or constructive tissues, they increase radiopacity, may require an increase in KVP or mass depending on what kind of tissue you have. So they increase the effective atomic number, or the Zeph number. Pleural effusion would be an example of pleural effusion, fluid where there should be air. So it would increase the tissue density and decrease radiographic density in the lung. So what we need to increase is mass for pleural effusion. Mass because what we were penetrating was lung, and now we're going to be penetrating fluid, and so we need to increase our mass. We don't want to increase KVP because we're going to create more scatter radiation with the fluid, and we don't want to compound the issue by increasing KVP. Pneumonia is additive. Unless it's a massive pneumonia, you really don't need to adjust your technique all that much, even though it is additive. The difference between a pleural effusion, a big pleural effusion, and a pneumonia is pneumonia is going to be localized to just a small area. Casting types of casting material, you need to know what type of casting material you're looking at. Is it fiberglass? Is it wet fiberglass? Is it plaster? Is it wet plaster? So if it's dry fiberglass, you don't need to make any kind of adjustments at all. If it's wet fiberglass, you're going to need to increase, and you can increase your KVP or your mass, either one. If it's wet plaster, you're going to have to increase significantly. You're looking at maybe a double of your mass, maybe a 10 KVP increase or a 15% increase in KVP is pretty significant. Aneurysms are additive, but they don't really call for an increase in technique. Atelectasis, that depends on what's causing the atelectasis. The atelectasis itself is going to be an increase. It's going to be additive because you've taken all the lung tissue that should fill up one side of the thoracic cavity and you've compressed it. So the atelectasis itself is additive, but what's causing the atelectasis? Is it pleural effusion? In which case you're going to have to increase your mass. Or is it a pneumothorax, which is a destructive pathology? And so you may have to decrease your KVP even for atelectasis. Ascites is just fluid, again, increase in mass. Osteoporosis or osteopetrosis, we already talked about. Acromegaly looks an awful lot like osteopetrosis, and acromegaly is giantism. So what you get is if the patient has reached the point where their growth plates have sealed up, you get an increase in the diameter of the bone, and you would need to increase mass, definitely, maybe even KVP. Oh, here we have the difference between an additive and really kind of destructive pathologies, or densities, I guess, is better said. So what we have is a very high density lung pathology. We don't really know what it is, but we can see that we can still see some what appears to be lung markings. So it would seem like what we've got is an opacified lung. So the lung itself is full of something. It looks like it's still inflated, possibly not down in here. But if these are lung markings, then we've got something going on there. So this would be caused by an increase in patient density, and what we get is a decrease in radiographic density. So you see the difference between the two lungs. You got this one that is full of goo, and it appears light on this side of the image. And over here, this presumably is a healthy lung, and it appears dark. High density, low density, radiographic density, caused by high patient density and low patient density. So I'm going to run through this again because it's very important that you get this, because you're going to struggle with this for 2 years. This is high radiographic density, very dark. This is low radiographic density, very light. Even looking at the spine, it's even lower radiographic density than what we have over here. A reason that it looks like this is because this is full of something that absorbs a lot of x-rays. So we have high patient density giving us low radiographic density. Over here we have low patient density giving us high radiographic density. Just to make sure I didn't mess that up, high patient density gives us low radiographic density. Low patient density gives us high radiographic density. So destructive pathology is very radiolucent, and it reduces or decreases radiopacity. So we get a decrease in the effective atomic number, and some obvious examples that we see are pneumothorax, emphysema, rheumatoid arthritis, osteoporosis, but possibly TB. TB is really kind of squirrely. In between, okay, so what you may see on TB are lines in the upper portion of the thoracic cavity that increase patient density and decrease radiographic density. But in between those lines, you may have the exact opposite going on, which is going to decrease patient density and increase radiographic density. Atrophy. Atrophy goes back to what I was talking about before with hyperplasia and hypoplasia. Atrophy is a result of hypoplasia. So sometimes you'll see atrophy in patients who are paralytics. If a patient is paralyzed in one arm, let's say, for whatever reason, they had an accident, they're paralyzed in one arm, what you'll see is a difference between the good arm and the bad arm, because the bad arm doesn't get used. So it'll atrophy, and the bone will take on an appearance like osteoporosis. So it'll decrease patient density and increase radiographic density to the point that the bone and the soft tissue are almost the same density over time. So how do you know what you're dealing with? Well, first thing what you need to get in the habit of doing is checking the chart. I know that some of your charts are in the computer system now, but it's important to understand what it is that you're taking the exam for. So check the chart, check with the nurse, look for telltale indicators. If you walk into the patient's room, they've got an NG tube, then that's an indicator that the patient, the NG tube is a feeding tube, but it's also an indicator that the patient may have a bowel obstruction. So look at the NG tube. Is it hooked up to suction? Is the suction canister full of bile? And if so, if you walk in and the patient's got a big distended abdomen and they've got an NG tube hooked up to suction and the suction canister is full of bile, that's your indication the patient has bowel obstruction. So bowel obstruction carries with it a lot of air. You would decrease your technique. But if you walk into the patient's room and they look puffy, and if you touch their skin, it's very soft and it doesn't rebound quickly. It rebounds more like a memory foam pillow or a mattress. That's an indication that the patient has ascites. They're maybe full of fluid, in which case you would increase your mass. If you walk into the patient's room and you're looking for a chest x-ray, well, what are you shooting the chest x-ray for? If there is a medical tray, sterile medical tray that's open, and there's guide wires and blood in the tray, take a look and see if it looks like the patient has a brand new central line. Because the central line, the danger of a central line is not the placement of the central line itself, but it is what might have happened when they placed that central line. So if they went into the patient's subclavian and they went too deep, the patient might have a pneumothorax, in which case it's more important to see the edge of that lung to see whether or not the patient truly has a pneumothorax. Or did they have a chest tube placement? Was this chest tube because the patient had a pneumothorax? So understand what your telltale indicators are, check the history, and understand that whenever you're taking an image for central line versus pneumothorax, which is more important? If you have conflicting possibilities, again, go back and check with the nurse, and you could even ask the patient, okay, they've got a central line in, how hard was it for the doctor to put the central line in? And if the patient says, oh, it was brutal, it took him 20 minutes to get it in there, then that's an indication that you may have a pneumothorax. So now you got to consider what's more important technique-wise. Do I need to back off on my technique a little bit to see the pneumothorax, or do I need to increase my technique a little bit to see the central line? Realistically, with your computer processing, you can probably see both of them, but just to play it safe, you might want to back off a little bit if you're looking for a pneumothorax, or increase just a little bit so that you can see a central line.